everyone, this is Mrs. Franson and I'm recording this lecture for you just in case we don't have time to finish it in class. So today we're going to be talking about substance abuse and dealing with patients that have substance abuse or addictive disorders. Okay, this is a list of some of the major major substances that you'll see patients that have difficulties with. We know that 50% of patients with a substance abuse problem also have at least one other co-occurring mental health disorder, and vice versa. So this lets us know that there's a genetic vulnerability that's similar between these two issues. Substances and addictive behaviors like gambling increase dopamine and glutamine in the brain in the same way. And if you'd like to learn how to recognize if your patient is addicted to these disorders, these different substances, and what might happen, then please look at Table 22.1. Table 22.1 is a very important table for you to know because you want to know what to expect and what might be wrong with your patient if they show up like on a med-surg floor and they're showing the effects of addictive substances. These concepts are central to addictive use behaviors and disorders, so please make sure you understand these definitions. They're defined on pages 413 through 16. Substance abuse is a disease that affects the pleasure or the brain or the reward area of the brain. This area is the neural pathway of the brain limbic system, the frontal cortex, and the brain stem. Addiction affects not only how the person experiences feelings of pleasure, memory and motivation are also powerfully affected. For example, marijuana impairs learning, it decreases memory, and it can have a profound effect on the level of motivation that the person feels. We think that at least 50% of people over age 12 use alcohol on a regular basis, and of these people we think that at least a third of them binge drink. In any given patient population, we think that about 10% of them are going to have a substance abuse disorder, and we know that this is higher in certain populations. For example, it's much higher among Alaskan Natives and American Indians, and patient population composed of people in their 20s are going to have the highest rate of substance abuse of any other decade of life. I want you to think about that because what are people doing in their 20s? Usually they're reproducing. So OB patients, pediatric patients, there may be a lot of substance abuse issues in the parents of pediatric patients and among OB patients that are going to affect their care. The younger the age at first use of drugs, the more likely the individual is going to be to have a substance abuse issue as an adult. We know that men are twice as likely as women to abuse drugs, and so we need to think accordingly. Now, sometimes drugs are used by people that don't have mental illness, and they develop the symptoms of mental illness from the drugs, like psychosis, paranoia, cognitive disorders, memory loss. We know that some people out there may have a mild form of mental illness and they have never been diagnosed, and we call that subclinical symptoms. And they may be abusing drugs to get rid of these subclinical symptoms that they're feeling. We also know that people with psychotic disorders like schizophrenia should not use drugs and drink because it makes their symptoms worse. And we know that psychiatric illness and substance abuse have some common risk factors. What are those risk factors? Genetic vulnerabilities, underlying brain defects, and exposure to stress or trauma at an early age. One of the things that I think is most important for you to understand is the neurobiological factors of addiction. When a person starts abusing a substance, that substance can actually hijack the reward pathway circuits in the brain. And I'd like to use an example of cocaine because cocaine is the most powerful example I can think of to tell you about. When a person uses cocaine for the very first time, the brain releases 10 times the normal level of dopamine, and the circuitry for pleasure in the brain is altered with just one use. So from that point forward, that individual will not have the same ability to experience pleasure in the traditional way because their brain has actually been changed. And if they continue on abusing cocaine, they will lose the ability to experience pleasure. And the only pleasure they can feel is from using cocaine. And eventually that will also go away, and they will have to use cocaine just to maintain a feeling of being normal. Psychological factors, people under a lot of stress and trauma, for example, early childhood abuse or combat experience, have higher rates of wanting to abuse substances. And there are some sociocultural factors like poverty, lack of parental supervision, and impaired support systems that cause higher rates of abuse. Now, you want to be able to assess your patients and figure out people that are under the influence of drugs that you're caring for or alcohol. So please look on pages 420 and 421 because there are some wonderful tables there that are going to help you understand the behavior and symptoms that you will see in many patients in the healthcare system based on whatever it is that they're abusing. When you assess a person with a substance abuse problem, you also need to look at the immediate circle of loved ones because you may have people in that circle that are enabling the patient or that are experiencing codependence. So let's make sure we know the difference between those two words. Enabling a patient means that the person may be doing something that is allowing the person to continue their addiction. For instance, they may be allowing them to live in the family home. They may be giving them money. They may be going to the store and buying their vodka. So whatever it is, it's enabling the addiction. Codependence is where the person becomes overly responsible for the addicted individual. They cross the line and try to take care of things that are not their responsibility, but are the responsibility of the person that is addicted. And they may do this out of love, but they are not helping the person when they do this. So let me give you an example. The 16-year-old crashes the family car, and so the dad reports to the insurance company and leaves out the information that the kid was drunk at the time. So he covers up his misdoing. He's trying to protect his child, but he's actually making the addiction worse when he does that kind of stuff. Now, I would like to look at codependence from another direction, and that's codependency and nurses. So excuse me just a minute while I find, here we go. I want to read something to you from your book. People who are codependent often define their self-worth in terms of caring for others to the exclusion of their own needs. Nurses are at risk for codependency since the very nature of the profession can lead to viewing oneself exclusively as a provider of care. I want to tell you about a large study among nursing students that was done about 10 years ago, and what they found was that nursing students had a very high rate, 48%, of having someone in their home that was addicted to a substance. And what that means is that they are at higher risk for relationship difficulties due to codependence because of a dysfunctional family when a family member is addicted. So I want all of you to think about codependency in nursing and guard yourself against codependent behavior. So let's review one more time. What is codependent behavior? Being overly responsible, defining your self-worth by what you can do for others, caring for others at the exclusion of your needs. So these things can result in you not living a full and satisfying life. So don't do that. Now when you're planning care for a patient, you have to look and say, okay, what point in the addictive process is this person? How addicted are they? Are they experiencing withdrawal? And what are their major problems that need to be addressed? So you may run into an individual on the med-surg floor that's getting ready to go into withdrawal. So that needs to be identified, and you need to contact a physician so that you can get a detox protocol in place for this person. So when we're looking at our patients that are addicted, we want to identify their major problems and decide what we want to do for them. And then we may also need to decide where would we recommend they go to get this treatment and what type of interventions are going to help them. Some of the things we need to look at is, are they withdrawing? Are they motivated for treatment? Do they have a support group in place for when they get through treatment? And what are their immediate needs? Do they have some safety issues? And we need to share all of this information with the physician. Now there are going to be a lot of patients that you run into that are going to go into withdrawal in traditional medical care areas where you're trying to treat them. So remember that detox is going to be necessary if the abused substance is known to cause withdrawal. And there's tons of things out there that cause withdrawal. Detox requires medical management in an inpatient setting. Most people going through withdrawal are going to experience many uncomfortable side effects, and some of them are going to experience life-threatening side effects. For example, when I first got out of nursing school and I was a brand new nurse working on a med-surg floor, we had an individual who was walking around our unit. He was going through withdrawal from alcoholism, and before any of us realized how terribly sick he was, he actually coded and died. So you want to take withdrawal very seriously. Examples of common addictions that require detox are going to be alcohol, heroin, cocaine, meth, and then your prescription drugs. particularly the opioids. These are some different levels of care that you can provide to someone with substance abuse issues. We've already talked about detox. Nothing can happen for a patient if they need detox and they don't get it. They must get through withdrawal and detox first. Then the decision can be made is, does this person want rehab? Are they ready? Do they have the desire to change? Do they want short-term rehab, long-term rehab, inpatient rehab, outpatient rehab? Are they a good candidate for partial hospitalization? Now, once they go through rehab, they can't just be left alone. They need support. So you have to think about, where are they going to live when they leave rehab? What is their support system going to look like? What community resources are available to help this person to maintain sobriety? Advanced practice nurses can offer counseling to the patient, and these are some of the counseling methods that they will use. I'd like to talk to you for just a minute about motivational interviewing. This is a way of interviewing the patient to help them break down the walls of denial, and this is very helpful with substance abuse patients. And also, FRAMES is a method that some people use with patients that are addicted, and what FRAMES stands for is feedback about their personal risk, personal responsibility, advice to change, menu of treatment or self-help options, and empathic communication. Now, whether we're advanced practice or not, we can all use empathic therapeutic communication with our patients. So let's review that for a minute. Let's pretend like the patient makes this statement to us. I'm so confused. My son just visited and wants to know where the safety deposit box key is. Okay, here are 4 potential nurse responses. We want to be empathic, not sympathetic. Empathy is empowering. Sympathy is not good for our patients. It actually makes them weaker. So, which of these responses are sympathetic? I'm so sorry that that happened to you. I feel so sad for you that your son has hurt you. Those are sympathetic responses. We don't want to use those. Empathic responses are reflection, restatement, or clarification. The patient needs to know we understand what they're going through and we have heard them. So let's use a reflective statement. You're confused because your son asked for the safety deposit key. Or let's use a clarifying statement. Are you confused about the purpose of your son's visit? Now, if you don't know the difference between sympathy and empathy, and you don't know the therapeutic methods of reflection, restatement, or clarification, please review these things in your book. We also use certain drugs to treat people that are addicted. And if you'll look on table 22.9, you will see a list of some of the common drugs that we use with our patients. And I'd like you to make sure you understand about Atabuse. Atabuse is used with alcoholics that are trying to overcome their addiction. They need to take it at the same time each day. Atabuse will make them very sick if they drink alcohol. So it's a deterrent. Librium and phenobarbital are used as protocols for withdrawal. This reduces the symptoms of withdrawal. It decreases the potential for the patient to begin seizing and just makes the whole withdrawal process easier for them to get through physically. Now, methadone we use to replace a drug that is more dangerous. Methadone is a narcotic. It's an opioid. It's very addicting. So why would we give this drug to patients? Because what they're addicted to is more dangerous than methadone. For example, women that are addicted to heroin or cocaine and they become pregnant often choose to go on methadone during their pregnancy. And I'll give you an example. I may have a woman come in to labor and delivery on cocaine, and the first blood pressure I take will be 220 over 160. The next blood pressure I take 2 minutes later will be 110 over 50. Her vital signs have gone crazy. She's experiencing tremendous damage to her heart and the vessels of her body. The blood flow to her baby is being compromised. So fetal and maternal well-being is threatened by drugs like cocaine and heroin. Many of these women voluntarily go on methadone throughout their pregnancy so that they can have a safer delivery and a healthier baby. When we get ready to discharge our patient into the community, we want to know what are the community resources to help them. And these are some examples of those. We know that the longer the individual can stay in touch with treatment organizations, the longer they're going to be able to remain abstinent. So let's suppose we had a patient that was admitted to the psych unit that was diagnosed with both major depressive disorder and a substance abuse disorder. So what are the shared risk factors? Genetic vulnerability, underlying brain defects, and stress and trauma at an early age. The slide also shows you some pictures that were part of a long-term study on methamphetamine. So one of the things you have to think about as a nurse when you're dealing with patients, particularly patients on med-surg floors, is how much damage is being done to them physically by the substance that they're abusing. Now, some substances are slow. I've taken care of many med-surg patients that have abused alcohol for 30, 40 or more years. So this is a substance that takes a terrible toll on the body, but it does it slowly. Other things like cocaine, heroin, and meth are going to take a toll on the body in a very shocking and rapid way. And this is an example of that. You're going to see some profound physical changes in these patients within the first few years of their addiction. What are the negative consequences that patients experience when they become addicted to a substance? Their work life gets disrupted. Most of them are going to lose their job. Their health begins to deteriorate either fast or slow, depending on what they're abusing. If they're in college, they're going to flunk out. Their family is going to become dysfunctional and it may eventually disintegrate. They may get involved with domestic violence. Their parenting is going to be disruptive. They may start abusing their children. They may eventually become involved in crime to support their addiction, and they may eventually die. You see a lot of people die from abuse. And I'm sure I don't have to point out to you the many celebrities that die and end up in the newspaper, and their problem is based on substance abuse. Okay, so when you're getting ready to discharge a patient, you want to think about their support system, the community resources for this person, and how are they going to, is all of that in place for them to go forward and be successful? Let's talk for just a minute about the long-term effects of alcohol on our med-surg patients. There's no part of the body that is not affected by alcohol, from the brain to the toes. And a particularly damaged part of the body from alcohol is the GI tract. So the rates of cancer from the GI tract, from the lips to the anus, are significantly higher for people that use alcohol. They have higher rates of lip cancer, mouth cancer, throat cancer, particularly esophageal cancer, stomach cancer, intestinal cancer, colon cancer, and rectal cancer. They also have higher rates of stroke and heart disease. Women who drink have higher rates of both breast and cervical cancer. Of course, liver disease is famous for its association with alcoholism, and all types of liver disease and liver cancers are very escalated in people who drink. You will see a lot of neurological deterioration and disease in people on med-surg floors that are long-term drinkers. So you're going to start seeing this in people in their 40s and 50s and 60s. So just remember that addiction has both a psychological and a physical toll on our patients. This patient is being discharged with a prescription of Atabuse. So what do you want to tell them? You want to tell them what's going to happen if they drink, and you want to let them know they need to take Atabuse at the same time each day. The nurse is caring for 4 patients who are going through detox for alcohol. So which one of these is the number one priority? Well, fine motor tremors are common in alcoholics, so it's not that one. They're sweating and have diarrhea. It's not that, because that's a normal part of detoxing. And so the answer is D. If they're hallucinating and delusional, they may have brain damage from their alcohol intake, and they're going through a severe form of withdrawal. So that would be your number one priority. The spouse of the alcoholic goes around the house and pours all the alcohol down the sink. So what type of behavior is this? Is it enabling, or is it codependency? If you don't know the answer, you need to look this up and make sure you understand. It's time for you to assess your patient. They recently abused morphine, so how should their eyes look? Should they be dilated or should they be constricted? And what about their vital signs? How is this morphine going to affect their heart rate, their blood pressure, or their respiratory rate? Please read about this. Make sure that you can be a safe nurse and recognize how people respond to these various substances so that you'll be able to successfully assess them. Have a great day. Good luck on your test.